This is Dr. Kachikian from the Black Hills Regional Eye Institute, and today we've got a case of a posterior polar cataract. It's always somewhat concerning with the posterior polar cataract because you never really are certain if the posterior capsule is completely intact or not. And typically, oftentimes these are younger patients, and so you want to be very careful because you want to try, if there is a posterior opening, you want to try and preserve as much of the posterior capsule as possible and do not want to lose, obviously, any nucleus posteriorly. You want to give the patient the best visual outcome. So I begin the case in a typical way, but by staining the anterior capsule. I always find that when you have the potential of a posterior capsular tear and maybe doing a vitrectomy and so on and so forth, it is always much more helpful to be able to clearly see the anterior capsular demarcation. And so it's just a precaution. Clearly the red reflex is visible, but it's always nice to be able to definitively see the edge of the capsular rhexis in case the case requires more manipulation. It's always nice in young patients to have a stained capsule in case the rhexis has any likelihood of radializing. Here we're making our about 5 millimeter, 5.5 millimeter capsular rhexis. I do like to have a big capsular rhexis in general, but not so big as to prevent optic capture with the off chance that there is a posterior capsular opening. And there we've got a nice round capsular rhexis. It's very well centered. It's very clear, and throughout the case you'll notice the edge of the capsule is very clear. Now, as you know, in these cases of posterior polar cataracts, we're not going to do hydrodissection. We are going to do a hydrodelineation, and really I just try and do very minimal separation of the cortex from the anterior capsule. There's no injecting here. There's just that almost manual separation of the anterior capsule from the cortex. We're not looking for this fluid wave to go posteriorly or to increase any pressure. Now we're going to go into the nuclear material here, and there's a beautiful hydrodelineation, and we're just going to make sure that that is separated 360 degrees, and so then you've got your epinucleus separated from your endonucleus, and you haven't disturbed that posterior polar plaque. You put a little more viscoelastic into the eye, and then because this is a softer cataract, we're going in with the phaco handpiece, but we're really going to use mostly aspiration, and we're going to use minimal phaco, but kind of very judicially to use the phacoemulsification energy because we don't want to disturb that posterior capsular plaque. And so at certain times we may find ourselves using some phaco energy to remove pieces of nucleus in an attempt not to disturb the posterior plaque or disturb the entire nucleus. And so here we are using the second instrument as well as the phaco handpiece to really separate that endonucleus. And there you go, you get a big nice piece, really using the second instrument. I almost call that a reverse chop because a lot of times when it is a softer lens, I'll actually put the second instrument into the center of the lens and push outward towards the periphery, towards that kind of endonuclear delineation in the periphery where we've done your hydrodelineation, and create a chop that way. It's almost kind of a reverse chop. And so here we are using that second instrument to manipulate the endonucleus there, separate the endonucleus from the epinucleus, make sure there we go, checking all that endonucleus, making sure it's all separated, getting out as much as we possibly can so that there is minimal endonuclear material left when we go to actually attack that posterior polar plaque and see if there's any opening there. And up until this point, really, I'm really not sure if there is a hole in the posterior capsule or not. Really, in these sorts of cases, I think the second instrument becomes really much more helpful to free up any peripheral material. Now we're going to reacquire the viscoelastic. We're going to place that in the eye, get a little space, make sure that we reinflate the eye before the phaco handpiece comes out because we don't want to shallow the chamber. That could break the posterior capsule. Now we are going to use viscoelastic material to try and separate the epinucleus from the capsular sac. And sometimes this is hard, especially if you're using, depending on if you're using a cohesive or a dispersive, sometimes hard to actually create that viscodissection plane. There it is right there. In certain areas, you might not be able to create that plane, and then you just wind up filling the eye with a little bit of viscoelastic, and that's not the goal. The goal really is to create this viscodissection plane to get out the epinucleus now, because we've already removed the endonucleus. So here we are, we're going to remove the epinucleus, and we're going to find out what the status of that plaque is and whether there is a connection between the vitreous cavity and the posterior chamber here. So we gently kind of tease out that epinuclear material. Again, part of the goal, and there comes that plaque, and let's see what's behind there. There is kind of an opening, but the anterior chamber is staying very stable. The fluidics are very stable, and boy, it really doesn't appear as though there is a posterior capsular opening here at this point. Again, we just want to be very gentle because despite the fact that there may not be an active open posterior capsule, the capsular membrane in that area is extremely thin. And so an acute change in fluidics or in anterior chamber pressure or any of those things could cause that capsule to rupture. And so we're constantly trying to balance pressure by not letting the chamber shallow. That was perfect. We got that main handpiece out of there, didn't let the chamber shallow at all. But we also want to be able to remove the epinuclear material. So we kind of think that there's no opening behind that plaque, but we weren't able to get all of the epinuclear material out. And so we switch over to maybe a gentler IA handpiece, and now we're going to use the IA handpiece to remove the remainder of the epinuclear material and the cortical material. And this really, I think, requires just a lot of patience, because they always say viscoelastic is cheaper than vitreous, and so time is also a little bit cheaper than vitreous, really, because it's worth spending the time now to gently remove the epinuclear and cortical material than it is to be overly aggressive with the phaco handpiece and then wind up having an open posterior capsule or vitreous prolapse, because you could even get through the case, even if the posterior capsule was open, with proper management of fluidics and viscoelastic. You could have an open posterior capsule, a nice round posterior capsular opening, fill your capsular bag with Provisc despite the opening, and still put an IOL in without you losing any vitreous. And so that's the goal. Okay, so now we've got most of the epinucleus removed. There's still some subincisional left. We'll work on getting that. Just kind of gently teasing it. Again, patience is key here. See if we can just kind of tease it out. It doesn't really want to come. And so at some point in the case, you're like, okay, let me just take whatever comes here, get it out of the eye, because at some point, if there is a posterior capsular opening, you just want as little material as possible. And so if you spend a lot of time getting the more difficult to access cortical and epinuclear material, and you neglect all the other stuff, and then you wind up with an open posterior capsule, then you've got a lot of cleanup to do. And so if you take what comes more easily, if you do have a tear in the posterior capsule, when everything's said and done, there's less cleanup to be done. So now we're going to come out with our IA handpiece. With put a little more Provisc in the IA handpiece to maintain the anterior chamber, not to allow that posterior capsular break. We're getting our very last bit of cortex See if we can get that all out, and then we're going to get ready to put our lens in. And the posterior capsule, fortunately, was intact in this case. We were very gentle in that there was no significant change in the anterior chamber pressure that would have caused any capsular trampolining. Here we go again, reinflating posterior capsule, and we're getting ready to put our lens in. And in general, even if there had been a posterior capsular opening in this case, it is unlikely that we would have lost a significant amount of vitreous because of the maintenance of the anterior chamber. Here we are with our IOL. We're going to very gently inject that into the capsular bag and allow that to open. Again, I don't want to distend the capsular bag too much. I want to make sure the IOL is folded properly so that it fits easily into the capsular bag. And here it's kind of verticalizing here. We'll rotate that and just try and sneak that elbow past the posterior, that trailing elbow into the posterior capsule. There you go. Or into the capsular bag. We're going to rotate that into position. And then we will gently do our irrigation aspiration. I do always go behind the lens when I do IA, and I'll do the same here, just to quickly get out whatever provisc is behind the lens to avoid any pressure spikes. Again, we're not allowing any capsular trampolining, so I'm not concerned about posterior capsular rupture. And we're going to remove now all our anterior viscoelastic. The cornea was coated well. We had excellent maintenance of the anterior chamber. We didn't allow any shallowing. We hydrodelineated. Then we viscodissect the epinucleus once the endonucleus had been removed. And those are the key steps to allowing an optimal outcome for these patients. Because again, oftentimes these patients are younger. They've seen very well most of their lives. They've known they've had a cataract, but they probably don't realize how serious the condition can be. Here again, keeping the anterior chamber inflated while we remove our IA handpiece. But they've seen well all their lives. They've known they had a cataract, and they may not realize the seriousness of the surgery. And so you want to make their experience the same as every other patient who has a cataract surgery experience. That's usually a good experience, and you don't want them to need any secondary surgeries, secondary IOLs, anything like that. And we'll spend a little time chasing this little piece that doesn't want to come out of the anterior chamber. See if we can kind of flush it out just gently through the main incision. Thought it came out. Didn't. And you know, even if we left that in there, it probably wouldn't be that big a deal. Kind of tend to dissolve. Okay, there it goes. Alright, so we're going to hydrate the roof of the incision, hydrate our side incisions, make sure our lens is centered, and make sure the pressure is good. And that is our case. Hopefully that was helpful if you've got a posterior polar cataract coming up. And remember, about a third of these have opium posterior capsules. The other 2/3 usually don't. And so good luck with your case.